a topic which is close to my heart because we often get these children referred from pediatricians. They have tried treatments and it has not worked. They continue to have this wetting problem, and they want us to evaluate and make sure that everything is fine. Now, this is appropriate to have this talk 2 days before World Bedwetting Day, which is happening on 26th of May, 2020. And in that regard, it is very nice to have this discussion today. And I want to start with some terminologies. There are a lot of terminologies like enuresis, incontinence, nocturia, overactive bladder, and bowel bladder disturbance. We need to understand the difference between some of these terminologies. I'll be going through all of them in the due course of this talk. Now, in the past, enuresis is referred to inappropriate or involuntary discharge of urine past the age of the usual control, which is considered to be developmental age of 5 to 7 years. So what I mean by this is this involuntary discharge means this child empties the bladder. For example, this dad is holding the child and playing with the child. Now, if this child empties his bladder onto the dad, he's not going to worry about it or run to a doctor. He'll rather laugh at the situation, and he will actually not worry about it because he knows that the child still has not developed the control of the bladder. So that is a typical enuresis which happens before the development of the bladder. On the other hand, incontinence refers to a loss of urine or leak of urine. So this is a leak of the urine which can be beyond the age of expected control, like 5 to 7 years, or parents can even notice it while they are little infants. For example, the mother will be able to say that there is a small leak of urine in between his normal voiding, or she will say that he never voids normally. So she will say that, you know, there is in between some soiling and there is constant dribbling. All these things the parents can very clearly tell. Now, there are a lot of pathological inabilities there as a cause of this. So incontinence is generally considered pathological, and it can be urge incontinence, stress incontinence, overflow incontinence. So this is what we initially had in our teachings, where the incontinence is pathological, and enuresis probably is not that pathological. It is either physiological or functional. This is what we've been taught during our college days. Now, the International Continence Society for Children, so they came up with a lot of definitions in the year 2006, and they further defined these terminologies, and they modified and clarified on it. And then in the year 2006, they came up with this document of revised terminologies of what we call as wetting. So the ICCS terminology of 2006 simply refers to incontinence. It doesn't have any other term. Incontinence means a leak. So a leak means incontinence. So the incontinence can be continuous incontinence or intermittent incontinence. So a continuous incontinence is where there is an organic problem like an ectopic ureter or some problem with the genitalia like bladder exstrophy or epispadias or one of those. Whereas intermittent incontinence is where there is in between problems like you either have this control or no control. So this can be classified into daytime incontinence or nighttime incontinence, and the nighttime incontinence is called enuresis. So there is no diurnal enuresis. So enuresis means nocturnal incontinence. So this is further classified into monosymptomatic and non-monosymptomatic or polysymptomatic, which means there are other symptoms like frequency, urgency, incontinence, and all those things. And they can further be classified into primary and secondary. I'll come to this later. Development of the bladder control, you need to understand a little bit about this to understand wetting, the causes of wetting. The number of voids per day is pretty high during infancy. So in the first year of life, it is around 20 per day. And then in the second year, it is around 11 per day. And in the third, and as they grow older to 7 years, it becomes like 5 times per day. And the voluntary control of voiding happens somewhere around 2.5 years. So it occurs a little bit early in girls like around 2¼ years, and in boys a little later, like 2¾ years. And up to 4 years, this process of attaining continence may continue. So before 4 to 5 years, we don't really brand them as abnormal, pathological. So the control pattern is also like this. The children attain nighttime bowel control first, then daytime bowel control, then daytime bladder control, then nighttime bladder control, which comes last. The development of the bladder control during infancy, the voiding is a reflex act. That means once the bladder is full, they have to empty. So the brainstem centers basically control the reflex, and cortical inhibition is poorly developed. So the cortical inhibition is something which helps us to control our urge to void in unsociable conditions, like in a school or in a meeting. The cortex can give us a negative input, whereas this cortical inhibition is not there. The cortical afferent is there. That means the child will wake up during the voiding. So the mother often complains that every time the child voids, the child is waking up in the night. This is quite normal. Only the child cannot control and inhibit the voiding. So the storage occurs at a low pressure. That means no instability, but the voiding is at a higher pressure in infants. That means when they void, they tend to habitually contract the sphincter, and that causes some dysenergia. So a child with enuresis, again I want to re-emphasize, it is nocturnal, it's not diurnal. So enuresis is classified into primary and secondary. So the primary is where there is less than 7 months of dry periods, whereas secondary means there may be more than 6 months period of dryness. So there may be 1 year gap or 2 year gap in the wetting. And that can be again monosymptomatic, where there is only monosymptomatic, that bedwetting, that is the term for primary monosymptomatic nocturnal enuresis, whereas it can be polysymptomatic, where there is urgency, frequency, dysuria, all those things can be associated with those nighttime wetting. Now the causes of this wetting can be functional, neuropathic, or structural. Functional means there is no actual pathology, but the problem is something to do with the behavior of the various organs and the way the bladder works. Whereas neuropathic means there is some problem with the neurology, the brainstem, the spinal cord, everything can be abnormal. And the structural abnormalities, like sometimes in ectopic ureters or epispadias, those are structural abnormalities which can cause a wetting. Now, this is a typical voiding diary, also known as frequency volume chart. Now, I always insist on my patients to record it for at least 15 days and then come back to me with the chart to go further. The reason being, this gives me a lot of information about what is happening during the night, what is happening during the day, particularly during the day. What happens during the day, I need to know to make sure that this is only a monosymptomatic nocturnal enuresis. So let us take this example of a 9-year-old girl who weighs around some 30 kilos. So the expected bladder capacity for her is something like 300 ml. So that is worked up by the age plus 1 times 30. So that is 10 times 30 is 300 ml. And then the urine output, you work out like ml per kilo. So that is for 24 hours, it probably will come to 720 ml. So that is the urine output you expect. Now, when they start recording the frequency volume chart, this is a very simple tool. What you expect them is like they void once in the morning, and the blue are all the school. So when they are at school, they probably void during the first break, void during the middle break, and then void during the third break. And then this is the voiding episodes in the evening and night. So roughly around they void around 7 times. And this is the kind of volumes you expect them to void. So the number of voids is something like 7 times, and they avoid. You expect them to void something like this. But what actually happens is they don't really void like this. So what happens is they void like they skip the first break. They void the entire volume in the second break. Then they skip the afternoon break. Then when they come back home, they go running to the toilet from the van, and then that is when they void the maximum volume. And then in the evening, they are at home, so they are conveniently voiding frequently. So this is smaller volumes. So this is how a typical voiding chart is. It looks in a school-going child these days. Still, they void around 7 times a day. more in the evenings, but less during the daytime. But the maximal bladder capacity, so the maximal bladder capacity is this. So this is what they void during the day. Whereas if they bring out a chart like this, for example, this child has voided 15 times a day, and the maximum voided capacity during the day is something like 60 ml, has never voided more than 60 ml. So this is a typical problem with the frequency of urine, and so the maximal voided volume is expressed as a percentage of estimated bladder capacity. So this is the maximal bladder voided volume, and this is the expected bladder capacity. So it is considered low if it is less than 65%, and it is considered high if it is more than 150%. So this is the ICCS definitions for maximal voided volumes. Now the ICCS definitions also has certain things like a frequency. If a child is voiding more than 8 times, it is called increased frequency. If a child is voiding less than 3 times, it is called decreased frequency. Now nocturia is waking up at night to void. Now this need not be abnormal. For example, if a child wakes up in the night to void urine, that doesn't mean that there is abnormality. It just means that the child has got a sensation and then waking up ability to do it. Nocturnal polyuria is different. So nocturnal polyuria, some physicians admit the patient, put a catheter and monitor the urine output over the day and then over the night. They want to know what is happening. If they measure it, then there are some formulas for this. So if it is more than 130% of the expected bladder capacity, then you call it a nocturnal polyuria. For example, in an expected bladder capacity in a 9-year-old child, we saw that it is 300 ml. The expected bladder capacity, if it is more than 400 ml, this is in the nighttime voiding, then you call it a nocturnal polyuria. So nocturnal polyuria can also be recorded as a percentage of total urine output. It is more than 20% urine output. You call it a nocturnal polyuria. Now coming to history taking, there are several important points you need to know in history taking. So is the wetting a problem during the night or only during the day? This is the most important thing I ask. Then is the wetting new? Has the child been wet before? And also how long the child has been dry, if the child has been dry before. Then again, this is the same thing, continuous or intermittent. Are there normal voiding episode? So by this, what I mean is in between wetting, is the child able to fill the bladder, have the sensation and empty it also. So that is important. Then are there any preventive body posturing in the form of leg crossing, squatting, Vincent's curtsy? So all those things. And are there features of bladder instability in the form of urgency, frequency, urge incontinence? Then, so this is a typical Vincent's curtsy. Vincent's curtsy means it can be different forms, but essentially it is crossing of the legs or pinching of the perineum or using the heel to compress the perineum in a squatting position. So these are all holding maneuvers. That means the child has got quite a bit of urgency and the child is trying to control it with various methods of using striated muscles. So the history often gives a clue, and history is the most crucial thing in a child with wetting. So if it is a pure nighttime problem, then it is most likely to be a primary nocturnal enuresis. If the child has been dry before, like for example, up to 5 years, the child has been dry, up to 10 years, the child has been dry, then organic causes are very unlikely. Continuous wetting, that means organic causes are likely, like for example, epispadias, ectopic ureter or urogenital sinus. Intermittent daytime wetting can be because of functional causes or urinary tract infections, can be associated bowel problems can be there. That can be Detrusor external sphincter dyssynergia or bowel bladder dysfunction due to functional constipation as well as bladder disturbance. So this can be a purely functional problem, but it can also be due to a neurogenic cause. So bowel problem present means it can be either a severe functional bowel bladder disturbance or it can be a neurogenic problem like a spina bifida or sacral agenesis. Now, this is a child, this is a little girl who wets soon after voiding. Now, what you have to be aware of it is, of course, this posture of the slide I have put mainly because you don't want to have the child hanging for the life from the toilet seat. So this is actually bad posturing. The other thing is their child is sitting with the legs put together. So what can happen is they can have what is called a vaginal voiding. So this is a problem in girls where the urine refluxes. It's very hard to demonstrate it, but sometimes you can see that during voiding it goes up into the vagina. So that is a vaginal voiding, and the way to treat it is just to make them sit with the legs wide apart, and the problems are sorted. So they have typical post-void dribbling of a few mLs. They don't have other symptoms, and vaginal voiding is something just to be suspected. Now, labial synechiae is another simple problem. You really don't need extensive evaluation for this. A simple separation of labia under anesthesia is what is needed. In very small children, if they are uncooperative, you often need a general anesthesia. So you simply have to separate it and then maybe keep on applying some lubricants to keep the labial adhesions open. So clinical examination of the abdomen involves looking for a palpable bladder. It can be a feature of an obstruction. For example, the child may have a posterior urethral valve, and this dribbling can be an overflow incontinence. The second thing is expressible bladder. So if you can express the bladder, that means it's a very highly likely to have a neuropathy. In a normal child, even in a newborn, you cannot express the bladder by a simple pressure, which is known as a Creed's maneuver. You cannot express it because the sphincters are pretty tight. It will resist your whatever pressure you give. Whereas in somebody with a poor sphincter control because of a neurological problem, you press the bladder, the urine leaks. So that is an expressible bladder. Then you palpating the abdomen for fecal masses, fecal loading. All those things are essential to look for functional and neurogenic causes. To the genitalia, you have to look for epispadias, meatal stenosis, fused labia, as I told. And in the spine, you look for hairy patch, a swelling or a sinus. And in the neurology, the things to look for is the gait. Gait is an important thing. Lower limb wasting, lower limb reflexes, particularly ankle jerk is something which you have to do. You have to examine the lower limb for sensation, and there may be some trophic changes in the foot. Example, loss of sensation in the lateral border of the foot, and maybe some trophic ulcer, trophic, all those things. So you have to look for all those things. So this is a typical epispadias where the bladder neck may be incontinent. So this is a simple epispadias in a boy, and this is an epispadias in a girl where you look for a bifid clitoris. So that is a feature of a epispadias in a girl. Tuft of hair is a sign of spina bifida occulta. So you can look for anal tone. The anal tone is often lax in this patient. Absent bulbocavernous reflex, ankle jerk, and then sacral sensation. Sensation over the S1, S2, S3 dermatomes. All those things can be looked for in a patient with the spina bifida occulta. When you palpate, you have to palpate the spine. You have to palpate the sacrum up to coccyx. If there is a flat sacrum and absence of coccyx, or if the anus is posteriorly placed, in patients with the sacral agenesis, the anus is often displaced posteriorly. So you will have a lot of perineum and the anus is posteriorly placed. So that is a feature of a sacral agenesis. Now, looking at the investigations, you often end up doing urine routine, urine osmolality, culture sensitivity, then ultrasonography to look for duplication anomalies like hydroureter, and that can be suggestive of an ectopic ureter, then upper tract dilatation, then bladder wall thickening, which can be a feature of an obstruction or a neurogenic bladder, then a residual volume. A residual volume, high post-void residual is something which is very important to measure. An X-ray abdomen is very useful to look for fecal loading. X-ray of the spine can reveal a spina bifida occulta, or you can do an MRI. Then voiding cystourethrogram, also known as MCU, that is to look for obstruction or look for a neuropathy or look for reflex. Then uroflow and urodynamic study as the last thing, which may need a complete evaluation of the upper tract. So structural problems, when to suspect an ectopic ureter. It is a typical problem in a girl who has always been wet. So by this, they will have a soggy genitalia. The genital skin will look like a washerman's skin with a lot of wrinkles, and it's damp all the time. they will have normal voiding cycle. So they will fill, they empty, and they have a good bladder sensation. But in between filling, and there is a small trickle happening all the time. They often do not have the features of urgency, urgent continence, or the features of the neuropathic bladder. Ultrasound may reveal hydroureter, but it may not reveal hydroureter. The reason being, often the hydroureter is from a dysplastic upper moiety. It may be picked up on an IVU, or it may be picked up on a DMSA scan. So in an IVU, it may just be a non-functioning upper moiety with hydronephrosis, and this is the lower moiety calyces which is seen. So that is called a drooping lily appearance. So that is a typical feature where you have the missing upper moiety there. So that is a feature of an ectopic ureter. In a DMSA scan, it can be seen as a small area of kidney upper portion which is not functioning. So that can be a feature of an ectopic ureter. An ectopic ureter, although rare, it is a completely curable problem, and this is something which we can cure surgically. So often you have a non-functioning upper moiety, and these children may benefit from a laparoscopic heminephrectomy. So that is a patient, a 6-year-old, who presented, and then this is an MRI scan which shows a dilated ureter all the way. It is going behind the bladder, and this patient has got a partial duplication. And when we do a cystoscopy, we found that that opening is actually in the vagina. So that is the vaginal tract, and we found the opening, and then we catheterized. So this patient underwent a laparoscopic nephrectomy of the involving upper moiety. So all we have to do is to remove the affected portion of the kidney, clip the vessels, and then trace the ureter as low as possible, and then remove the ectopic ureter also. So that is a dissection of the vessels. Often they are very little strands, but sometimes you see big vessels which need clipping. And once you have clipped the vessels, you often end up putting 2 clips, and then you can remove the entire specimen. Now, if the kidney is functioning, if the upper moiety is functioning, you do not have to do a nephrectomy. So in that case, this is a 28-year-old female who had a constant wetting since childhood. So she was never evaluated, and after marriage, her husband said that we will evaluate and get it fixed. So she had an MRI scan, and then that MRI showed a ectopic ureter going all the way, but she had a functioning upper moiety of the ureter. So we decided that we won't remove it, but we will rather divert it inside. So that is a laparoscopic ureterostomy. So what we did was we disconnected the ectopic ureter and then joined it. So what you see, you can see the 2 ureters here. That is the ectopic ureter which is dilated. So we are dividing it, and then we are going to join it to the other ureter which is the normally opening into the bladder. Now what we have done is we have already left a stent and a ureteric catheter inside the normal ureter. So when you open the normal ureter on the side wall, you will see the stent there, and then maybe a ureteric catheter also. So what we are going to do is we are going to do an end to side anastomosis. The ectopic ureter is going to, the end of the ectopic ureter is going to join to the side of the normal ureter. So that is the suturing of the ureter to the normal ureter. So the ectopic ureter is now diverted internally into the ureter which is opening from the lower moiety, but actually into the bladder. So this is done with continuous sutures using laparoscopy. That is the vicarial sutures, and that is the posterior layer of the ureter being anastomosed, the upper moiety and lower moiety ureter being anastomosed. And once this is completed, we will disconnect the ectopic ureter. You may leave a clip on it. You probably no need to leave a clip on it also, because it is opening ectopically. So in this patient, we decided to clip it. So that is the completion of the ectopic ureter anastomosis. And once this is done, we will pass the stent across from one of the things. So it becomes like a wide duplication essentially. So that is the division of that ectopic ureter. We have put a clip there, and then we have started anastomosing the anterior layer of that ureter. And then we will reposition this ureteric catheter into the other ureter. So these tubes will be kept for a week, and then the stent will be kept for another 4 or 5 weeks. So after that, we close this, and then this becomes like a wide duplication. So that is a management of ectopic ureter in a case of a functioning upper moiety of ectopic ureter. Now, neuropathic bladders, when to suspect a neuropathy? So, when there is a severe incontinence, which is a continuous leakage of urine, when there are bowel problems like constipation and soiling, when the bladder is expressible, when there is a gait abnormality or abnormalities of the lower limb reflexes, the spine may have occult or overt features, or there may be sacral abnormalities. Ultrasound often shows bilateral hydronephrosis, thickening of the bladder, post-void residual volume, and then MCU shows an abnormal bladder shape. An X-ray or an MRI may give a suggestion. So this is a spina bifida occulta, which is seen on an X-ray. There is only a problem with the spine. That is a lipomeningocele, which it appears like a little bulge, but when you do an MRI, you can see that the lipomeningocele is there. So this is a meningocele where there is a bulging of that meninges and then the fluid there. Here there is a myelomeningocele where there is bulging of the neural elements also. So this is a myelomeningocele. Now, tethered cord is another problem where it's very difficult to suspect by any of these methods. All you get is a 6-year-old girl who suddenly starts sweating, and when you examine, there may not be much neurological change, but when you do an MRI, you will see a tethered cord. So that is a tethered cord tethered to the some of the sacral, the fibers are tethered there. A tethered cord can be a part of a post-myelomeningocele repair or lipomeningocele, or it can be simply an isolated tethered cord, which is very difficult to diagnose. So that can be a cause of a neurogenic bladder. Now, in children who have had an imperforate anus, so this is a typical posterior sagittal anorexoplasty or pull-through operation for imperforate anus. These patients may develop neurogenic bladder because the innervation to the bladder is disturbed during the pull-through surgery. So that can present with a neurogenic bladder. So that is a typical appearance of a neurogenic bladder, also known as Christmas tree appearance. So this is something which you need to be aware of whenever you get to see an image. You see a picture like a Christmas tree appearance, you got a neurogenic bladder. So I'm not going to the complete management, it's a big chapter. Now coming to the functional problems, when to suspect avoiding dysfunction. So they have a daytime symptoms, they have frequency, urgency, urge incontinence, constipation, squatting maneuvers, they may have urinary tract infections. Ultrasound can often be normal. Uroflow abnormalities are often there. Now, bowel bladder dysfunction is the latest term. It used to be called dysfunctional elimination syndrome, but they don't want to use the word syndrome anymore, so they call it bowel bladder dysfunction. So this X-ray shows a lot of loading of the colon. So if there is this much of constipation, obviously the bladder is not going to fill properly, and you have to treat the constipation first and then only take care of the bladder problem. So you have to start at the bottom end. You have to give bowel wash, enemas, maybe one of those polyethylene glycol powders to clear it from the upper end, and then also start them on lactulose. So you have to do all the possible methods to deal with it. Coming to overactive bladder, that is the new term for urge syndrome. It used to be called urge syndrome, but now it is being called overactive bladder. So it affects 3% of girls and 2% of boys. Mainly daytime problem. They can also have nighttime problem. They have frequency, urgency. They have this typical urgency and then holding, but they can't hold, and that becomes urge incontinence. Vincent's curtsy sign. They use external sphincter and pelvic muscles to counter the bladder pressures that leads to incomplete voiding. They can have spontaneous resolution. Now, this is another problem where there is called voiding postponement. This used to be called a lazy bladder syndrome, but now it is called voiding postponement. So that is characterized by large capacity hypotonic bladder, decreased frequency, deferred voiding. So these children, they are afraid to use the dirty toilet in the schools. I often tell that the problem is not, you won't get it by going to the toilet. So we often know this is the image from this movie, Three Idiots, where this person who is ragging passes, but Rancho keeps a spoon with electricity there, and the current passes on the urinary stream. So the bacteria don't climb up fast like a current. They cannot come back into the bladder. So passing a urine into a dirty toilet doesn't actually get you a urine infection. But if you hold on to the urine for a long time, that itself will be a cause of a urinary tract infection. So incontinence between voiding episodes due to overflow, decreased sensation of the bladder or the fullness, and incomplete emptying predisposing to urinary tract infection. So that is a problem with the voiding postponement. So we should make sure that they have a normal frequency. If they have too much frequency, more than 8, that is abnormal. If they have too less frequency, less than 3, that is also equally abnormal. Now, Detrusor sphincter dyssynergia used to be the old term. Now it is called dysfunctional voiding. That refers to inappropriate contraction of the external urinary sphincter during voiding. So these patients develop a typical what is called a spinning top urethra. So this spinning top urethra, whenever you see it on voiding cystourethrogram, it can be seen in girls also. So that is a typical feature of a Detrusor external sphincter dyssynergia, also known as dysfunctional voiding. Now, uroflowmetry is one simple test which is a non-invasive. Of course, it can be used only in a child older than 5 years, who can pass and pass the urine on the machine, the uroflow machine. But for the urologists, they know that a normal uroflow looks like this. It's a bell-shaped curve. So when you have a curve like this, a tower-shaped curve, that means they can't hold it for too long. They started immediately, they reach high pressures. That is a feature of a overactive bladder. So the bladder is ready to go anytime. So they generate high pressure, but a quick void. Now this is a feature of a dysfunctional voiding or Detrusor sphincter dyssynergia, where there is a interrupted voiding. The flow is prolonged, and then you have a lot of contractions of the external sphincter. So when you put an electromyography lead on the perineum, you'll know that there is also contraction during the voiding. Now this particular curve, which is there, it is a feature of a abdominal voiding. So the child voids with abdominal pressure. This is completely atonic bladder. So abdomen contracts, the child voids and it stops. Then another abdominal contraction, voiding, abdominal contraction, voiding. So that's a typical feature of an atonic bladder. And this is a feature of an obstruction. So for example, a posterior urethral valve with an overflow incontinence. So there's a poor prolonged flow. So a uroflow is a simple test which can give you a lot of information on what is going on. What is urotherapy? So urotherapy can be a standard therapy where the therapist sits with the children and the parents and gives a lot of advices on the lifestyle. Like for example, bowel bladder training, behavioral modification, what to drink, what not to drink, what to eat, what not to eat, and how to sit, how to relax, how to avoid. All those things, these are done as a separate session in clinical settings abroad. It can be specific therapy in the form of a neuromodulation. Neuromodulation means transcutaneous electrical nerve stimulation. This can be sacral neuromodulation or posterior tibial neuromodulation. So this is what we do in our institute. Sometimes we give them this is sacral transcutaneous electric neuromodulation. So we stimulate the S2, S3 dermatomes, and that over a period of time helps them to overcome the hyperactive bladder. It can also be, the urotherapy may also involve stitching them clean intermittent catheterization, or it may involve giving them biofeedback. So what is biofeedback? So biofeedback is a method where the children are taught using machines to relax their external sphincter, and they are taught how to unlearn the bad habits they have kind of learned over the years. So this is a child who is undergoing biofeedback. So the external sphincter is connected to an EMG electrode, and it is a typical like a video game. So whenever the external sphincter contracts, the fish opens the mouth, and then when they relax, the fish closes the mouth. So there's a jellyfish, and the child knows how to catch the jellyfish. So the child has to relax the sphincter to go and catch the jellyfish. So this is how the children are taught how to relax the external sphincter, and that is a very useful part of biofeedback treatment for these children. Now coming to the most important topic of this session, the primary monosymptomatic nocturnal enuresis or bedwetting. This is a common problem. 2/3 of them are boys. It has got a genetic predisposition. There are chromosomes involved in 12, 13, and 21. So it can run in families. If one parent is affected, there is a 44% chance. When both parents are affected, there's a 77% chance. When neither parent is affected, around 50%, 15% chance is there. Now, this is a common problem. When you look at 7-year-old children, it occurs in 5 to 10%. For example, if you take a school where you take all the second standard children, if there are 100 children, definitely 10 will have bedwetting. But every year, 1 in 7 children get better. And then by around 15 years, when they reach 10th standard, then only 1 out of 100 will have bedwetting. Now, coming to the causes of bedwetting, it can be a combination of 3 different things. It can be because of a polyuria. I told about nocturnal polyuria, which is more than 130% of that bladder capacity. So it can be nocturnal polyuria, or it can be arousal mechanism where they cannot be woken up, or it can be an associated instability where it becomes a polysymptomatic. So these are the 3 components of bedwetting. Now, how do you know somebody has got nocturnal polyuria? They wet soon after going to sleep. They have a large wet patch. It's a literal flooding of the blood. And they have dry nights only if the child is waken up and taken to the toilet. And if the urine concentration, when you look for a specific gravity, there's a weak urine concentration. So these are all suggestions of nocturnal polyuria. Bladder instability, we have already discussed this. They have urgency, frequency, urge incontinence, low voided volumes. They often have multiple wettings at night. Unlike the children with other problems, they have small volumes, so they wet 2 or 3 times. But one of the important things is they may often wake up. Some of these children have nocturia. They wake up sometimes to go to toilet, but sometimes they cannot wake up, and that is when they go for this emptying of the bladder. So what happens is when you have a bladder instability, you have a history of 2 to 3 times wetting in the bed in the night. Now, lack of arousal, you all know who this character is, Kumbhakarnan. So he sleeps, you can't wake them up. So this is they have a problem in waking up from the sleep. So they have an arousal problem. So they sleep through the wetting, and they cannot be woken up. So that is a problem. So how to choose treatment? So nocturnal polyuria, if you suspect, then treatment is desmopressin. Lack of arousal, the alarms, star charts, and biofeedback is the treatment. And the bladder instability means you have anticholinergics. So the treatment differs based on what your history and what your assessment tells you. Now, behavioral therapy, there are certain things which can help. Like, for example, you have at least 6 to 7 drinks a day and then void regularly. So this is something which we need to tell them. During the daytime, they should have adequate intake. They should have adequate bladder filling. They should have a normal sensation. So that is essential for them to have a sensation of the bladder. Then they should stop drinking and eating 2 hours before the sleep. So I tell all my patients, you finish your dinner much earlier, like 7:38 p.m. And then you make sure that you don't drink a large quantity. If at all you become thirsty, you have a small sip in a spoon, maybe an ice water, but you have only in spoons after 7:38 p.m. And it's essential that they empty their bladder before they go to bed. Then avoid bladder stimulants like tea, coffee, hot chocolate, Coke, blackcurrant, any caffeinated drinks they should avoid. And ensure easy access to the bathroom. So in some of the villages, the bathroom may be in a far end of the house. Often they have the long house where the end of the bathroom is at the end where there is very poorly lit. So that proper lighting and proper access has to be there to the bathroom. Then rewarding the dry nights like a star chart. So this is a star chart. Typically they get rewarding. So each reward gives them a positive feedback to the brain, and then over a period of time they learn that they have to overcome their problem. So they encourage a child to participate in changing the bed, but do not scold or punish the child, because they are not doing it out of their wish to wet the bed. They are actually doing it because they cannot. So it is not a willful problem, so we should not be punishing them. Desmopressin, predictors of success are nocturnal polyuria, low urine osmolality, family history, wetting early in the sleep. So I often end up giving 0.2 milligram to start with tablet. There is a spray and there is a melt tablet. I have a problem with the sprays because they do not know whether they have taken properly or whether the absorption has been proper. So I prefer a tablet. Side effects: headache, stomach pain, nausea, hyponatremia. Hyponatremia is something which you have to warn, because once they have taken the desmopressin tablet, if they keep on drinking water, then they are at risk of this problem. So you have to restrict the fluid intake. So 7:30, 8 o'clock, you stop eating, take the tablet, and then don't take it after that. Don't drink after that. Then we check the response every 3 months by withdrawing the medication, and a structured withdrawal program. So for example, after 1.5 months, you do it alternate days, then twice a week, then once in a fortnight, and then stop it. So slow withdrawal program. The most important thing is you have to warn the parents of the relapse when stopped. I give the example of diabetes. You take insulin, the diabetes is under control. You stop insulin, the diabetes comes back. So it's exactly like that. So I tell them that the desmopressin trial is only to know that your child is going to be all right during the tablet. Now, we cannot give desmopressin forever, but at least you know that the desmopressin is working. The reason why we need to know this is because when they go to a friend's house for a sleepover, or they go to a relative's house, you don't want to wet their bed. When you travel in train, you don't want to flood the person below in your lower berth. So at least during those occasions, you can use desmopressin. So they are very happy to stop it and then use it on occasions of visits if I want them in advance. But if I don't tell them that there will be a relapse, they are all getting worried about it. Now the third important thing is alarms. Alarms in the Indian setting, basically how it works, like it is an alarm for the family. The second child wakes up, the father wakes up, the grandmother wakes up. Maybe if it is a flat, the neighbors also wake up, but the child doesn't wake up. So this is a typical problem with alarms in our setup. So a typical enuresis alarm is a small portable device worn on the body at bedtime. It should provide a tactical stimulus in response to wetting. So if the child starts little drops, the alarm wakes up the child with a sensory stimulus like a buzzing sound, not really a volume sound. So the goal is to beat the buzzer and wake up before the bladder feels full. So these are the typical alarms. They are worn in the perineum, and the alarms are giving a vibration to the child just to wake up the child. So these are the typical alarms we should be using, not the regular alarms which we use. So predictors of success are like they don't have any behavioral problems, normal bladder capacity, they wet late in the night, no daytime problems. So these are all predictors of success of alarms. Now, anticholinergic medications like oxybutynin typically work when you have a daytime symptom like urgency, frequency, and multiple wetting episodes in the night. You can combine it with the desmopressin to increase the efficacy. You start with a 2.5 to 5 milligram tablet of oxybutynin, and the side effects are there, like dry mouth, constipation, blurred vision, flushing. Hyperpyrexia is a particular problem in Indian setting where they don't sweat, so they cannot maintain their temperature, so they become hot. So anticholinergics are useful, and that can be an adjunct to our other methods. Tricyclic medications, imipramine has been approved by FDA for this treatment. It works by multiple mechanisms. It works by decreasing the REM sleep. It also acts like a stimulation of the antidiuretic hormone secretion, and it also relaxes the detrusor muscle. And there are a lot of side effects like hepatotoxicity and cardiotoxicity if we keep on using it, but it can be sometimes used in patients who fail to respond to any other therapy. So to summarize, a detailed history is essential to rule out potential secondary causes. Majority of them will have a typical primary nocturnal neurosis, monosymptomatic, and they grow out of the problem. Behavioral interventions are the first line of treatment. Enuresis alarms are effective, and they should be considered early in their treatment. And desmopressin is effective and should be used in conjunction with behavioral interventions. So I stop here, and then I thank you for organizing this. I'm planning to upload it on the YouTube to watch later. So I will let you know once it is ready. Thank you.